The osteosarcoma is a malignant tumor of the bone. It comes up with the osteoblast converting into malignant cells and creating abnormal osteoid. Um, as it is from osteoids, that's why they are mostly sclerotic lesion or blastic lesions. There are the incidence is bimodal with an early peak and the late peak. The early peak is one which is happening in the primary osteosarcomas, and the late peak happens because of secondary osteosarcoma formation. These lesions can be identified at the distal femur, proximal femur, proximal tibia, as well as the proximal humerus, rarely. The lesion, when identified, has a wide zone of transition depicting as malignant status. There are multiple associations like retinoblastoma and Rothman-Thompson disease. Retinoblastoma gene is basically a pro-oncogene. These tumors have predilection to go for a bone and pulmonary metastasis. 20% of the cases would have pulmonary metastasis on presentation or micrometastasis. There are multiple types of osteosarcomas. The intramedullary osteosarcoma is a high-grade osteosarcoma. It presents with genetical translocation like retinoblastoma gene, tumor suppressor gene, and can happen with Rothman-Thompson syndrome. Rothman-Thompson syndrome is a syndrome which is autosomal recessive with a mutation of RECQL4 gene. There is a sun-sensitive rash developing with pigmentation and skin changes. There is absent eyelashes, absent eyebrows and hair. There is juvenile cataract and teeth malformations as well. These patients have high risk of osteosarcoma, fibrosarcoma, and gastric adenosarcomas. The lesion is a high-grade lesion and needs neoadjuvant chemotherapy, surgical resection, and then chemotherapy post-resection. Another form is periosteal osteosarcoma. It arises from the outer layer of periosteum. It is mostly involving females and is involving posterior aspect of femur. This one lesion is that is periosteal osteosarcomas does not need chemotherapy itself. The treatment is surgical intervention. Appearance of it is like as bone stuck on the posterior aspect of the cortex. Then is a periosteal osteosarcoma, which develops from the inner layer of the periosteum.
Yes.
This has a sunburst appearance.
Pants and shirts. I'll take it out for you. Don't worry. It's a gray color.
It has a sunburst appearance involving proximal tibia, and it's a moderate weight. Then is a telangiectatic carcinosa osteosarcoma. It basically can arise in a previously aneurysmal bone cyst or a previous history of Paget disease or radiation after radiation exposure. These are blood-filled cavities, just like a aneurysmal bone cyst, but the spaces interstices are malignant. They have lakes of blood mixed with malignant cells. Regarding reviewing the patient such with osteosarcoma suspicion, I need to do clinical history, examination, Do lab investigations, especially alkaline phosphatase and CRP. Alkaline phosphatase can be raised in these cases. If I have a suspicion, I will do an MRI locally and do a distance shaded by the CT tab. Remembering the fact that the chest can be involved with micrometastasis. Regarding the prognosis, the neoadjuvant therapy has improved the survival. The poor prognostic factors include advanced stage, number 1, advanced stage of the disease, number 2, poor response to chemotherapy, number 3, high serum alkaline phosphatase, number 4, high LDH, number 5, expression of P-glycoprotein, and absence of normal protein like heat shock protein, HSP90 after chemotherapy. Treatment is MDT, a neoadjuvant and maintenance therapy for 6 to 12 months post-radiation. Agents which use are doxorubicin, cisplatin, and methotrexate. Neoadjuvant therapy helps to improve and treat the micrometastasis and reduce the inflammation and reduce the size of the tumor so that resection is easier. LDH can be used for monitoring of the patient. Osteonecrosis is the one indicator which is a good indicator. So with neoadjuvant chemotherapy, we can also identify which tumors are more responsive. A wide local resection is indicated, removing a part of the normal soft tissue or bone. An MRI will identify if there is a neurovascular invasion, which will need a resection or amputation instead of removal of tissue itself.